America's LGBTQ plus community says it's living in a state of emergency. The Human Rights Campaign reports over 500 anti-LGBTQ plus bills have been introduced in 41 states this year, and more than 75 have become law, and many of them deal with the right to health care.
And just because we do not have all the research done doesn't mean you ban gender-affirming care legislatively across the board and increase further barriers for kids and adolescents in particular, but also adults.
Our guests are Dr. Marwan Haddad, the immediate past chair of the HIV Medicine Association, and Dr. Carl Streed, the research lead for the GenderCare Center at Boston Medical Center, where he helps to assess and address the health and well-being of transgender and gender-diverse individuals.
I think one thing also to really point out around these bans is they're hyper-focused around access to medications and surgery, when gender-affirming care is really much more than either of those. And the care needed for youth is often more focused around educating the family, making sure the youth is supported, that they have a safe environment, and that their community is safe for them.
This is Conversations on Healthcare.
Well, welcome, Dr. Haddad and Dr. Streed, to Conversations on Healthcare.
Thanks for having us.
Yeah, good to
you.
see you both. Let's start with Dr. Streed. You're on the faculty at Boston University's Chobanian and Avadisian School of Medicine. In November, you'll become the president of the U.S. Professional Association for Transgender Health. The Human Rights Campaign says 35% of transgender youth live in states that have passed bans on gender-affirming care. What harm do you think this will cause if the bans are fully implemented?
Thanks for that question. I feel like it's important to recognize that while the bans themselves are egregious, they're not evidence-based, they're going to cause direct harm. I think it's important to recognize that the conversations even around these bans are really harming people even across different state borders. It's causing significant degrees of distress, anxiety, concerns around depression, and lots of questions around access even in neighboring states. Because a lot of folks are still having to travel to different clinics very far away because so few folks are actually able to provide gender-affirming care for youth and adolescents, and honestly, even adults. Myself, as a primary care doctor who provides gender-affirming care for adults, I have patients who are traveling hundreds of miles to access care because there aren't enough of us who are able to do that. I think one thing also to really point out around these bans is they're hyper-focused around access to medications and surgery, when gender-affirming care is really much more than either of those. And the care needed for youth is often more focused around educating the family, making sure the youth is supported, that they have a safe environment, and that their community is safe for them. Medications and surgery, if indicated, are only part of that conversation. They are not the only part of the conversation.
Well, Dr. Streed, as you know, a lot of conversation going on in the country, and supporters of these bills say that they're really just protecting children who are too young to understand the health impacts of such care. I wonder what you say in response to this issue, particularly of the age of children, and what does it mean to be too young?
Oh, I feel like this is such a loaded kind of question because we allow folks to make decisions at a variety of life-changing decisions at different ages. But again, the focus is really trying to make sure that the youth are supported in whatever decision they make that makes sense for them. And that this is not just somebody's made a decision all of a sudden and that the doctor is going to prescribe or going to do surgery immediately. This is always something that's been in conversation with a multidisciplinary team for a very long time, honestly, for many folks. This is not a decision that's made lightly for anyone. And this is a decision often made in conjunction with a multidisciplinary team and always with the support of family, essentially.
If I can just ask you to clarify, and we do hear this a lot about young. Are there age, or is there evidence for certain ages at which it's appropriate to begin having the conversation, or is it whenever the child and family are ready to have the conversation?
I think it's more about when the child and the family are ready to have the conversation. They're the ones who should be really, like the child, the youth, the adolescent are the ones who really should be dictating their care. That's how we need to be doing it in general. We should be listening to the patient in front of us. That being said, of course, we have very clear guidelines about when we may consider medical or surgical interventions. And those are the guidelines we should be following from the World Professional Association for Transgender Health, of which USPath is part of. So it's, again, one of those things where this is not uncharted territory, really. This is really something that has clear guidance, has expert input, has more and more evidence supporting the provision of this care. So it's more a situation that I often see where politicians are making policies without evidence and are not seeking the input of the people affected and not seeking the input of experts who are providing that care.
Well, Dr. Haddad, we, of course, know you very well. In the spirit of transparency, you're the director for the Center of Key Populations at the Community Health Center, and the health center is part of the Moses Weitzman Health System. And I'm wondering, what do health systems mean when they say they offer gender-affirming care and hormone therapy, and what does that involve?
Yeah, no, thanks for that question. I think it's very important to really sort of define what that is, because a lot of times I think people just focus and hone in on exactly what Dr. Streed was saying. It's about medications, and it is a lot more than that, right? So for me, it means that these health systems provide a welcoming, safe, respectful environment for the LGBT and transgender and gender diverse communities, and that all the staff is well-versed, well-trained, and culturally humble, right, when it comes to interacting with individuals in the LGBT community. It means, for instance, things like being able to accommodate and appropriately use people's names and pronouns. It means that we have expertise in providing quality care in issues and conditions that affect the LGBT and transgender populations, including medications like hormone therapy. But as a note, there's much more to delivering comprehensive patient-centered care, which is the bread and butter of primary care health centers like ours, much more than just hormones. And health systems, I think, need to understand and provide this holistic care. And lastly, I think, and ideally, they also have a resource and referral network that also provides safe and respectful care for the patients.
Well, maybe for both of you, are we losing this battle in terms of definition where everything is viewed only in one context? And what can we do to better educate people across the board about the more comprehensive view of the work that's going on here?
I mean, I feel like it always comes down to actually knowing who's affected and really sharing narratives, really sharing the stories of who's having trouble accessing care and highlighting the harms that are happening from this legislation that's already been passed in too many states. But also highlighting the positive benefits, the joy that we see from youth and adolescents and adults who are able to access gender-affirming care. I mean, honestly, for me as a clinician, there isn't a week that goes by where a patient isn't just happy, joyful, or will honestly say, like, you saved my life, by providing very broadly gender-affirming care. So we have to share that information. We have to share those stories. And then also we have to really lean into not backing down from any one of these battles. It's essentially, I kind of describe it as somebody is essentially setting fire in different homes, and we have to go to each one of them and put out each one of them with the same dedication we would for any others. Mm-hmm. So it is an ongoing fight to make sure that people know who's benefiting and who's being harmed by these egregious policies.
Well, that really goes to the recent study that found that transgender children are 3 times, I think, as likely as the general population to have anxiety and depression, neurodevelopmental disorders. And we note that the U.S. Justice Department has said, and I'm quoting here, no person should be denied access to necessary medical care just because of their transgender status, including transgender children. There's so many questions about this out there. And Dr. Haddad, what about the argument that the medications used for gender dysphoria lack the FDA's approval for this use? Where does that fit in?
Sure. So there are a lot of things, as we sort of say, that we don't have FDA approvals for that we use in medicine across the board, not just in transgender health. And so I think first we need to acknowledge wholeheartedly that we do need more research in gender-affirming care, and we need more funding for research, right? We need more active recruitment and inclusion of transgender and gender diverse individuals in all research across the board. But that doesn't mean that we don't know how to care for transgender and gender diverse individuals. As Dr. Streed said, in the US, we've got experts in many fields of medicine and prominent medical organizations that support the gender-affirming care, and that we have these guidance and guidelines. And just because we do not have all the research done doesn't mean you ban gender-affirming care legislatively across the board and increase further barriers for kids and adolescents in particular, but also adults in seeking the care they need and deserve. So gender-affirming care truly, as I think Dr. Streed was alluding to, means in many ways supporting the social transitioning. What do we mean by that? That means allowing kids to wear the clothes they want, cutting their hair like they want, playing with the toys that they want, providing that sort of safe support for families and for the patients to say that, yes, it is okay for you to sort of feel this way. It means providing the counseling. And at some point through all the shared decision-making, right, with providers, patients, with families, medications may be prescribed around the time when puberty, before puberty is going to hit. So puberty blockers do delay onset of puberty. And so you can start those until such a decision is made, shared, right, when they want to go through puberty and which puberty they want to go through based on their gender identity. We hear from our patients all the time that if a trans kid is about to go through the puberty of the gender that you do not identify with, that is a very serious and critical time and a dangerous time for them. And so I think a lot of these decisions are made together with the families, with the providers. What has to happen, though, is that we cannot have that interference and being dictated by legislation. These are decisions that are made in the context of the provider-patient relationship, and they need to remain there. And as we sort of said, the harm in withholding this care to the transgender community is really detrimental and can be fatal.
Dr. Streed, let me just pull the thread on Dr. Haddad's statement about more research needing to be done. Critics say instead of offering puberty blockers, clinicians should understand children could just be going through a phase and that watchful waiting and talk therapy should be used for gender dysphoria. I'm wondering if that's an area of research, and also what's your reaction when you hear comments like that?
I mean, my general reaction is I'm getting tired of us having to try and chase the moving finish line, as it were, in terms of, this is the evidence that we need, or this is the research question that people should be focusing on. We should be focusing less on whether gender affirming care actually is good or bad, and focus more on how can we do it better, and how can we make sure that we reduce any potential risk from any intervention, just like we do for any medical or surgical intervention. We have to really understand and characterize it. Right now, we're fighting the battle of is it good or not? And honestly, anybody who's actually providing gender affirming care can see it firsthand and within their own patient population. Any researcher who does this seriously can also see at a population level that there is significant benefit from the provision of gender affirming care, including medicine, surgery, as well as broader additional services. So my general response is exasperation when people are asking for more research to prove that it is beneficial or not. But overall, there's so much within medical and surgical care that, yes, we need more research. We always need more research to better characterize the care we're providing. Just because we need more research, that does not mean we stop providing the care. Honestly, just because we have issues with regards to potential adverse outcomes, that does not mean we stop providing the care, because we then find ways to actually reduce the adverse outcomes. We then find ways to make sure who's going to benefit the most from the interventions, and so on and so forth. Too much do people focus on very small numbers of adverse outcomes for only apparently gender affirming care, rather than looking at adverse outcomes for anything else. Again, this just for me highlights the ideological and political motivations around these bans, rather than the actual evidence or care about youth and children, or the constituents of these elected officials.
We just had on from NYU Langone, the lead researcher for a long COVID study, which is the first in the nation. And obviously, we've been treating long COVID in many different ways without the results of this, but it's a work in progress. Any research that you're keeping a watchful eye on that's going on that some of our listeners might want to also be aware of?
So there's already great publications from a multi-site longitudinal study of youth and adolescents receiving gender-affirming care. This is actually an NIH-funded study. They've published in the New England Journal of Medicine, highlighting a number of psychological and mental health benefits of gender-affirming care. I'm always eager to see what they're going to keep churning out, because this is a multi-year process. They're going to be the leaders, honestly, in terms of what can we expect around gender-affirming care for youth and adolescents. Again, though, what I like about the study is they're not focused on whether this is good or bad. They're focused on who's benefiting, who could benefit more, and what do we need to understand about any kind of outcomes from that. I think that's what people should be keeping an eye out for. I also want to highlight that there's more research focused around conversion therapy or essentially the harmful attempts to try and change somebody's gender identity to make it either be cisgender or cisgender with a sexual minority identity. And more research is really highlighting the harms of that approach. And that has often been the response to, we don't do gender affirming care. We actually really try and convince people that they are actually the gender that they were assigned at birth. And we know that that practice is harmful and really needs to be continued to be banned. And more research will continue to show that more likely.
Well, I know that both of you are probably equally expert at the one-on-one relationship with the patient and the exam room and the family, but also in the national circles where the policies are being made and dialogue is happening. The American Medical Association and the Academy of Pediatrics both support gender-affirming care. The Pediatrics Academy just authorized an expanded set of guidance based on the systematic review of the evidence. But we have this pushback. Florida says not enough scientific evidence to prove that treatments improve health. And the United Kingdom, I understand, is largely stopping the use of puberty blockers, citing this gap in evidence. That's a lot, I know, to unpack, but I'm curious if you're finding that the support from your professional associations is clear and strong enough that you feel you have that backing of the professional associations going forward, or any concerns in that area that there's going to be a push on professional associations to move in a different direction?
I'm personally grateful for our professional associations for actually, again, sticking to the evidence and not caving to any kind of pressure. As somebody who is actively involved in organized medicine through the American College of Physicians, Society for General and Internal Medicine, the American Medical Association, these are all associations that have really focused on trying to make sure that we understand the evidence, that we acknowledge where there are gaps, and really try and push the science forward and make sure that clinical care is based on that. There, of course, has been political pressure. The American Medical Association, when they really stood up against any kind of legislation around the provision of gender-affirming care, received very targeted threats. And the AMA has not backed down. And I think that's what we really need to see from our professional associations, is that we are clinicians, we are based in the provision of care for our patients, and we are focused on the evidence to do well by that. And these organizations, I do not think, are going to be caving to any kind of political pressure based on ideology, based on any kind of ill will towards a group of people who honestly have been targets for far too long.
Dr. Haddad, do you want to add anything to that, or?
You mean, sure. I think our associations have really been great at sort of stepping forward and pushing back against these legislations. But I think we cannot let our guards down. And to this point, I think we were always going to get sort of pushback. From my position at the HIVMA, I mean, we've been hearing about threats of pulling funding for pediatric residencies, right, who actually teach gender-affirming care. So all of a sudden, it's coming at all levels, and I think we need to constantly be very vigilant at the advocacy piece, at really truly honing it back down to what it is that we really want to do. Right. At the end of the day, we want to protect our children, our communities, and to do that, we truly need to engage all our communities in care. Right? And it's not by banning care, right, and treatments. It's by investing in this care. It's investing in the research that we need to further the betterment of the care, investing in the holistic care, improving the access and decreasing barriers to care, and building on what we know from experts as well. Instead, like what we said, what we're seeing is almost the complete opposite of what's happening. We need to continue to push back. You mentioned at the top of this, over 520 anti-LGBT bills in state legislatures this year alone. There are 22 states that have banned the medical and surgical care for trans youth, with 5 states making it a felony crime, right, to provide this medical care to youth. So you can imagine the impact not only on the patients, the communities, but on the medical sort of teams, on the recruitment of we talk about the workforce and the lack of the workforce. It's affecting recruiting good physicians and clinicians to these states to be able to provide this good care to patients. And we just need to continue to really focus on the advocacy and the voices and really push back. And so far, I feel, that our associations have really been doing that.
Mm-hmm. No, and Dr. Streed, you were talking a little earlier about gender at birth, and you've written the following: as clinicians, we strive to be accurate. The evidence shows that using male and female as the only options in birth certificates is not consistent with scientific reality. Wondering you can explain why you think the medical profession needs to do a better job of understanding and accepting this issue. And is it only in the medical arena, but also in the public health, the health departments and others who are really probably in control of what gets put in a birth certificate?
Absolutely. I mean, you're bringing up this notion of how we are trying to provide population statistics on who are we trying to take care of, essentially. But the notion of binary sex is something that has been only really recent in medical history in terms of from the late 1800s onwards. And it is not an accurate representation of all of the ways in which bodies are actually created, as it were. There are people with differences in sex development or intersex characteristics that do not fit neatly into our notions of a binary sex categorization. And oftentimes there's a lot of harm in trying to push people into those boxes. So there's been a significant movement to try and understand ways to update our medical training, update our public health, essentially statistics and data structures to try and avoid these potential harms, both intentional and unintentional. So there's been a lot of efforts to remove, for example, as you've alluded to, the sex designation on the public portion of the birth certificate. Because birth certificates are something that we carry with us for a number of issues, even though it makes no sense that I have to show my birth certificate for employment, it's there. And for trans individuals or people born with differences in sex development, that can be a very harrowing experience. It can be an experience where they are effectively outed and could be discriminated against based on that information. So we're trying to find ways of reducing unintentional harm from essentially government use of information around people's bodies, as it were. So there's much more we could talk about this. I do think this is a little, it's related to what we're talking about, but it's also a much bigger can of worms, as it were, because I'm talking about trying to break down binary categories, and the medical profession is so focused on binaries, and we are really trying to update that.
Well, we may have to come back and revisit the issue in another conversation, because it was certainly a fascinating one that I know I did not have on my radar. So I appreciate your comment there. And if I can, I want to turn to the issue of HIV and AIDS for a moment. It was 42 years ago that the reports came out from CDC on the clinical evidence of a disease that would later become known to all of us as AIDS. A question to both of you: where do things stand today in terms of diagnosis of people having access to testing and to being diagnosed if they're at risk, and also treatment?
Sure. So, I mean, I think, as we've talked about, we do have the tools to end the HIV epidemic, right? We've got great sort of tools for that. Yet, overall, we're still seeing over 36,000 new infections each year in the U.S. And these are preventable. And the majority are still among men of sex with men. A majority are in Black and African Americans, followed by Hispanics. And then transgender women are also disproportionately affected. Also, majority of in Black and Hispanic trans women. And we have excellent treatment for HIV. So if we're able to diagnose everyone with HIV and engage them in care and on treatment, first of all, their lifespan themselves will approach the expected lifespan of those without HIV. But if they're on treatment, they would also not transmit HIV to their sexual partners, regardless of the condom use, right? The whole concept of U equals U, undetectable equals untransmittable. And then for those who do not have HIV but continue to be exposed, we have pre-exposure prophylaxis, or PrEP, and that can prevent someone from acquiring HIV also regardless of condom use. And so we can end the HIV epidemic, and we can stop the new infections from occurring with these tools. Yet in the US, 1 in 3 people with HIV are not on treatment, and 3 out of 4 people who could benefit from PrEP are not on PrEP. So we have made major strides in the last sort of 4 decades, and yet it's that implementation of these tools that we are sort of failing in reaching everybody.
Well, I want to go to an area where there was incredible success in this area. And Dr. Haddad, you wrote a piece in the Journal of the American Medical Association with the title, "Ending the HIV Epidemic, We Have the Tools, Do We Have the Will?" You know, we had the great opportunity, we were out at the Aspen Ideas Health Initiative and had the opportunity to talk with Dr. Fauci. He and former Senate Majority leader, Bill Frist, were on stage talking about the work that happened with PEPFAR initiative. And that really reduced AIDS in underdeveloped countries. I'm wondering, given that that was so powerful a message that with the right will, with the right economic incentives, that we really can make transformational change. I'm wondering what kind of willpower is missing now.
Yeah, sort of to continue that thread that I sort of started talking about in terms of just now and within this piece, it's really about not the tools, because we have the tools, but it's really about the context that these tools are trying to be implemented in the US. And you mentioned PEPFAR. And as you know, I've worked in some of the PEPFAR countries as well in that front. And I will have to say that the PEPFAR countries, many of them are doing much better than the US in terms of really achieving the viral suppression rates that we need to be doing in order to truly end the HIV epidemic here in the US. And a lot of this is, it's also multifactorial as to what we need to be doing in the US. One, I think we need to concentrate on the workforce. We have a dwindling HIV workforce, and we need to build not only more, but we need to build a more diverse one that reflects the patients we're trying to reach and engage. The stigma and discrimination and the structural racism, that needs to be addressed. And it's not being addressed by passing these laws and policies that not help, but further embed the structural racism, the anti-women, anti-gay, anti-trans sort of laws that are sort of happening, that are pushing the people who are at the highest risk, who are getting infected right now with HIV, away from healthcare rather than bringing them into healthcare. We need to really be looking at, and by the way, all this structural racism and these disproportional sort of effects that have been having, we've known for decades in the HIV epidemic. But it took the COVID pandemic to truly highlight these inequities on a scale that now couldn't be ignored like it was being ignored in the HIV epidemic. And so fundamentally, we need to be focusing on these as basic civil and human rights issues. This is not an issue of HIV. This is not an issue of anything else but the basic fundamental civil and human rights. And so, we mentioned other things like mental health, substance use treatments, harm reduction approaches to all of this. This is a holistic approach. We need to be treating the syndemics of HIV and STIs and viral hepatitis and substance use and mental health. We're shutting down certain services programs. Right. So in West Virginia and Indiana, where we had outbreaks secondary to injection drug use of HIV and viral hepatitis, and we knew that certain services programs were working, they shut those down. And now we're seeing resurgences of infections that are driven by injection drug use. And we need to, as we said, create these safe and respectful environments for the LGBT community. We need to build the trust with racial and ethnic minoritized populations. And so, to near and dear to your hearts, I know, right? Ensuring affordable and comprehensive healthcare for all. And we need new innovative care models. The current care models that we have done so much and great stuff, but there's still this gap that we're missing. And so we really need to look at these new innovative care models that are going to address the social determinants of health. They're going to address the stigma and the discrimination, and really try to sort of bring in these populations, not even bring in. Actually, I recently heard this, that we need to stop thinking about bringing people into healthcare. We need to go out and meet the people where they're at. And that's what we need to be doing.
Do you think there are models that we should learn from in what's called the developing world? And Dr. Fauci reminded us when he went to Africa to figure out whether or not people could manage all of the dosages, the dosing that was required. He came back and said, my God, they're way ahead of us. They can manage all of this. I'm just wondering, do we have a similar situation where there's an intervention model that we can embrace? And of course, in the community health center world, Dr. Geiger comes out of South Africa with that community-oriented model that he brings back to America. So where might we learn from?
I think there's a lot to learn. The differentiated service delivery models that are implemented in all the PEPFAR countries are exactly what we need to start be doing here in the US. Looking at those who are doing really well, don't need to come in, and those who need more support to get more support on that front. So looking at this. Looking at street medicine and being able to get reimbursed and find ways to be able to sort of go out into the streets and meeting people where they're at. The use of community health workers and peers, which has been a big backbone of success in a lot of the PEPFAR countries that we are just starting to talk about here in the US. So there's definitely a lot of things that we can learn from the PEPFAR countries and bring them back to the US for us to improve our care.
Well, you point to so many great examples, and I know you're a big fan of the mobile vans as well as team vans that can go anywhere in the community where there are people we might need to reach. But we remember those early days of the HIV epidemic. We also remember quite a few people in healthcare who were not willing, ready, or able to step up and in and provide the kind of care that both of you do. And I understand, I maybe need clarification on it, that there are a number of states, they say more than 1 in 8 states where LGBTQ plus people are living, where doctors, nurses, other healthcare providers can legally refuse to treat them. This is according to the Movement Advancement Project. Now, I don't know whether that's refused to treat for anything from your dental care to your routine primary care, or it's specific to gender-affirming care and the care we've been talking about. But how much of a problem is this getting to be in terms of healthcare providers who perhaps have a very different view of all this, just refusing to see people at all?
I think it goes, I've gotten to the point where I tell my students and trainees that if you have any deeply held moral beliefs against the provision of any care to people you don't agree with, you're probably in the wrong profession. And if you are against the provision of gender-affirming care, that's all well and good, but you need to know who's going to be able to provide that care for your patients. And again, if you are against the provision of care based on deeply held moral beliefs, I'm very curious as to why you're in a caring profession where you need to be able to care for everyone who's coming to your door. The kind of legislation you're describing is providing inappropriate protection to discriminate, essentially, for healthcare professionals. It includes a number of professions, including pharmacists who won't provide, for example, Plan B, or won't dispense hormone therapy for trans individuals. And what it gets down to is that happens more often in what is, quote unquote, seen as not an emergent situation. Definitely is not allowed in ERs or surgical emergencies and such. But again, those laws are allowing clinicians to discriminate when they shouldn't be.
Thank you both for joining us, and thanks to our audience. Be sure to go online to chcradio.com to sign up for emails and updates. And again, thank you both for the important work that you're doing.
Thank you for having us.
Good.
Thank you for your time.
This copyrighted program is produced by Conversations on Healthcare and cannot be reproduced or retransmitted in whole or in part without the express written consent from Community Health Center, Inc. The views expressed by guests are their own, and they do not necessarily reflect the opinion of Conversations on Healthcare or its affiliated entities.